Take a seat and fasten your seat belt, yeah? Safe belt, yeah, safety belt. Okay, so you are in a session on the Supraflex Cruz, and the general title is Improving Patient Outcome from Simple to Complex Patient. And my job is very simple. I just want to introduce the panel. That was my role. You have from far away to close Helge, Joanna, Wykrzykowska. We have our spokesman, anchorman, whatever it is, Faisal, Sharif. Then you have Ignacio, Amat-Santos. And then we have Gianluca, Campo. And then we have Ashok, Seth, which is leading this meeting. And then Valeria, which is there. Okay, I think this it's a good audience. People are still coming in. And my role is already finished, so I will introduce the next, if we can open the next.
So thank you everybody for being here. I'm Faisal Sharif, one of the cardiologists in Galway University Hospital. I have a pleasure of working with Professor Serruys and all a very talented team in Galway. I'm just waiting for my slides to open. I'm just going to talk very briefly about the objectives of this session. So really the objectives are here to understand safety and efficacy of Supraflex stent in real-world clinical practice and randomized clinical trials. So we'll be hearing some very presentations on this subject. We will also like to demonstrate the safety and efficacy of Supraflex in high-risk patients, in diabetic population, elderly population, in patients with acute coronary syndrome and high bleeding risk. We would like to see contemporary use of new technologies and best practice PCI in 2024 using Supraflex Cruz in 3-vessel coronary artery disease. So before I pass it on, I would like to just talk a little bit about the stent technology itself. Supraflex Cruz is a sirolimus-eluting stent with a biodegradable polymer. It has ultra-thin thickness of 60 microns, regardless of the dimension of the stent. The unique characteristic is the connector between the two crowns, which is a Z-link connector, and allows it to have a very high pushability and flexibility, which is an important mix of the two features with any stent. The stent is an open cell design, and it comes in 3 different crown sizes. So you have 4, 6, or 8 crowns, depending on the diameter of the stent you're going to use. Charlie Gao et al. Did some bench testing and showed that it has the least amount of effort needed to push the stent, which is quite desirable, especially in using in populations which are now getting older, coming into the labs, and we need better deliverable stents. There is a comprehensive overexpansion possibilities for all diameters. So if you have any size you take, you have a reasonable amount of overexpansion across the range from 2.25 to 3.5 to 4.5. And you can see that it has very useful for bifurcation lesions, because the perimeter is the largest among the available current drug-eluting stents. It allows you better access to the side branch, and really important feature for bifurcation stenting. So I think this is just a few salient features of the ultra-thin Supraflex stents, and without any delay, I would like to ask the next speaker to come in, please.
Okay, that's good. Thank you very much, Faisal, for this introduction to the point with the key features. And then we will have, I call upon the Azfar for the first talk.
Okay, what I'm going to present to you is the data from the UK registry. These are my... So you've seen the details of the Supraflex Cruz stent, the Nevo. The majority of the data before it was launched in Europe was relating to South Asian population. So the UK SFlex second registry, we'd done the first one several years ago with the original Supraflex Cruz, was designed to test its performance, safety and performance in a largely European, UK-based population. So this registry was designed to evaluate the clinical safety and performance in an all-comers population, so a real-world registry. Prospective observational single multi-center registry, we had a baseline of 1,835 patients recruited pretty quickly, actually, from March 2020 to September 2021. There were 19 NHS hospitals across the UK, across the 3 nations of the United Kingdom. And the primary endpoint, real world, once again, was target lesion failure at 12 months, which was a composite of cardiac death, target vessel myocardial infarction, and clinically indicated target lesion revascularization. And geography was not mandated, so this was patient-reported outcome measures. If you look to the right, 1,835 patients, and at the end of 12 months of follow-up, we had 1,730 patients, and these were the reasons for the loss of numbers. Baseline characteristics, there were absolutely no selection criteria. The patients that were enrolled were purely at the mercy of the treating physician, and as you can see that this was a fairly complex patient population, typical of what we are doing in the United Kingdom, and it reflects very well our national database figures. So just over a fifth of patients had diabetes mellitus, 43% had multivessel disease, and 69% acute coronary syndrome. We had pre-specified subgroups given the numbers. Type A lesions were 2.2%, diabetes mellitus, as I said, 22%, 14.8% bifurcation, B2C lesions, and this is important, 84%. So this was not a simple lesion registry. 53.7% of patients had lesion length greater than 20 millimeters. Once again, if you look at the lesion characteristics, you start from the bottom, type B2C, 89%, diffuse, 56%, and moderate to heavy calcification, 30%. So just emphasizing the point that this was a complex patient population. Procedural characteristics, so diameter stenosis of 90%, and I think what I want to point out to you is that given the qualities of this stent that Faisal has presented, that the device success was 98%. Procedural success was 98%, and this is worth emphasizing given the complexity of the patient population and the lesion selected. What about the clinical follow-up at 12 months? So at 12 months, the target lesion failure was 2.3%, and these are the divisions of the side effects. A cardiac death, 0.8%. Any stent thrombosis, 0.3%, definite, 0.3%, probable 0. So very reassuring figures at 1 year. If we subdivide these events into the pre-specified subgroups of outcomes at 12 months follow-up, you can look at the target lesion failure to your left, 6.2% in the diabetic subgroups, but ranging from 1.8 to 2.7 in the other subgroups. If you come across to the right, stent thrombosis, reassuringly very, very low. And the same applies to cardiac death, target vessel MI, and target lesion revascularization. So if we look at the type A lesions, we've seen the data for the complex lesions. There was a request to put in for type A lesions because we always seem to present only for complex lesions. How does this stent behave in simple type A lesions? So from the overall 1835 patients, the subgroup analysis was only 39. And once again, I think it's a reflection of what modern interventionists are doing, not just in the UK, but as I go around across the world. Type A lesions are few and far between. We're taking on more and more challenging cases. As you would expect, even in type A lesions, the target lesion failure stent thrombosis rate was 0. So in summary, Chairman, panel, and ladies and gentlemen, the SFLEX UK2 registry provides an evidence of the clinical safety and performance of this new Supraflex Cruz sirolimus-eluting stent. Importantly, it was in an all-comers, unselected patient population presenting to UK centres. And it confirms the excellent overall safety and performance of Supraflex Cruz with low rates of target lesion failure and stent thrombosis at 12 months in both complex and simple lesions. So in summary, a real-world registry with real-world patients and real-world outcomes. Thank you for your attention.
So excellent, very encouraging result. I think I would like to take advantage of our discussion and speakers. So first, maybe a question of Helge for you. Short question, short answer, because we are on a tight schedule, and then Professor Upendra Kaul as a speaker can also have a question. We'll have to move to one of the microphones later on. But first, Helge.
Yeah, actually, I would like to ask about calcified lesions. I just realized that there were a lot of calcified lesions in the registry, 30%, and we have a very high success rate, 98%. So this is somehow astonishing. How does it fit together?
So it's encouraging because of what Faisal presented about the deliverability of this stent. So what is reassuring is that we see this in real practice. So the device failure specifically in moderate to heavy calcified lesions was 2.4%, which was 16 of the 612 moderate to calcified, heavy calcified lesions. So overall device failure rate 1.8, in moderate to heavy calcified 2.4%.
Very good. Ashok, maybe you go to the microphone and ask your question, if you have a question.
Yeah, I think...
Upendra, that was Upendra, sorry.
Okay.
Okay, welcome.
Use of intravascular imaging and, additional devices in these calcified lesions, rotablator and other things, yeah.
So that data specifically was not collected in this registry, but the use of imaging physiology is under 15% in the UK. So these were angiographically divided calcified lesions. I don't have the data for rotablation, but once again, what it tells us is that in this real-world registry, even with moderately heavily calcified lesions, with limited use of imaging, that this stent performs well.
Very good. Ashok will have the possibility to ask questions maybe later on,
okay.
Or now. You want to do now? Okay.
I would, because I'm intrigued. I think these are very impressive results, given the fact that 70% for these were ACS patients, type B to C, 2.3% TLF.
Yes.
Low MI rates.
Yes.
What was the definition of MI? What periprocedural MI taken into account?
No, so no, there were no blood tests. I said it's a real-world registry, real-world patients. These were patient-related outcomes. So if there was MI and the patients were admitted to hospital, that's how it was noted.
Okay, thanks.
Yeah. Very good. Very good. Thank you again. Yeah. Now I will call upon Arpad Lux from the Netherlands. He will present the Dutch registry of the Netherlands registry, whatever the name is. Yeah?
Yeah. Good afternoon. I'm pleased to share with you the interim results of our Dutch Supraflex registry. As you see, I'm giving this talk on behalf of Dr. IJsselmeiden, the PI of this study. So you all know, new generation drug-eluting stents are performing better than the first generation of the DES, with lower complications and low risk of complications. It is also known that the Supraflex family has favorable clinical outcomes in an Indian population, but at this moment it's less known how it performs in the other parts of the world. So we set up prospective registry with the primary objective to evaluate the safety and the efficacy of this stent platform. The study design is a straightforward one. It's a national, prospective, observational and multi-center study at 10 sites across the Netherlands. We are collecting data in the end from 7,000 patients, quite a lot in my opinion. And at this moment, we have data on more than 4,000 of these patients available. Follow-up is at 1 year clinically, and the primary endpoint is target lesion failure, defined as a composite endpoint of cardiac death, target vessel myocardial infarction, or clinically driven target lesion revascularization. These are the baseline characteristics of our population. As you see, this is also a generic, randomly selected population with an age of 67. Predominantly men. We have a lot of patients with hypertension, more than 50% of our population. A lot of people with hypocholesterolemia. And diabetes is approximately 20% of this population. we take a look at the indication for the procedures, we see that acute coronary syndrome is predominant, mostly non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. The rest is stable angina or silent ischemia. If we take a look at the procedural characteristics, we see that we have a very high device success rate, more than 99%. That combined with a high procedural success rate, also around the 99%. Our colleagues had to perform, in most of the cases, a pre-dilatation. There were a lot of stents implanted, and that in complex lesions in this population, this cohort, approximately 60% were type B C lesions, 4% chronic total occlusions, and 12% bifurcation lesions. At discharge, most of the patients had dual antiplatelet therapy, aspirin in combination with ticagrelor, 50% as expected, based on the amount of ACS patients, and the rest predominantly clopidogrel. When we compare the medication at discharge with the medication at 1 year follow-up, we see that at 1 year only 40% of our patients had dual antiplatelet therapy. That has to do something, in my opinion, with the planned interventions where we have a tendency to give shorter DAPT treatment, and the rest is the acute coronary syndromes, and it's reflected by the representation of the ticagrelor. Of course, treatment of coronary artery disease is not only treatment of the stenosis, but treatment of the disease itself. Surprisingly, we see that the beta blockers and the percentage of ACE inhibitors is decreasing during the year. Fortunately, statins stay at 80% with an increase in the percentage of other lipid-lowering drugs. The clinical outcomes, we have target vessel, cardiac death at 1.5%, with target vessel myocardial infarction around 1.7%. We see reassuringly low rate of stent thrombosis, under the 1%, with a definite stent thrombosis of 0.7%. If we take a look at the Kaplan-Meier curves, we see that the combined outcomes, primary outcome at 1 year is at 5.3% for the target lesion failure. And if we take a look at not only the target lesion, but the target vessel, about the target vessel as well, we see that it sits at 6%. In conclusion, I think it's safe to say that our registry also shows a favorable clinical outcome for the stent platform in the population and in the real-world population, and that these results are competitive, well, safety and efficacy with other registries and other data. Thank you for your attention.
Excellent presentation. The result looks very promising, Dr. Arpad. So are there any questions from the panel for Dr. Arpad?
Yeah, if I may.
Maybe, yeah.
First of all, I want to congratulate for this prospective real-life registry. This is crucial beyond the trials. I think this provides with the authenticity of what's happening in clinical practice, and the quality of the data were really good. What first came to my mind was the highest rate of TLF reported in this real-world trial compared to the previous trial, the UK, registry, and which is your explanation for that? Is the longer length stent, the more overlapping?
And that's an excellent and challenging question. But if you take a look at the baseline characteristics, we see that it's quite comparable. So we had a similar population in both registries. We see that we also had to treat complex patients, 60%, which is quite a high ratio as well. So I don't think that it's due to the population or the stent or technical issue. It's more probably something due to adjudication, how we are registering our data and how we're collecting data. I believe that we have to look at there how it's happening and how we record our procedures, how we define our procedures. Maybe if we control that one, that we have more complex procedures as well.
Are there any more questions from the panel? Maybe Dr. Valeria?
Yeah, about... There were also some bifurcation lesions and complex lesion. Do you have any specific comments about the stent characteristics and the stent platform in the bifurcation treatment? For example, access to side branch osteo?
Yeah, I mean, the stent, as we just heard in the first presentation, has all the characteristics needed for this kind of challenges with good side branch access, post-dilatation limits, which also warrants the good outcomes for this challenging population, where you can leave a good result, a safe result behind.
Very good. Excellent. Yeah. So the next presenter is Simone Biscaglia from Italy, and he's going to talk about his experience of the Cruz stent and maybe a case presentation.
Yes, exactly. Thank you very much. So yes, we will try to focus on, as it was said before, on a complex population. These are my disclosures. That basically was the one included in the FIRE trial, because this is what we will deal in the next 5 minutes. So in the FIRE trial, we included patients with at least 75 years of age and myocardial infarction as indication for PCI, so either ST segment or non-ST segment elevation MI. The patient had to be multivessel, so the treatment of the culprit lesion was warranted in all the patients, and after the treatment of the culprit lesion, patient could be randomized to either a complete revascularization guided by physiology or a culprit-only treatment. So these are the baseline characteristics of the study, just comparing the FIRE trial with all the other trials like the COMPLETE, the COMPARE, and all the culprit, all the other studies comparing culprit-only versus complete revascularization. You can see that obviously the age was higher because it was an inclusion criteria, but also the rate of diabetes, female patient, and patient with complex presentation was higher. If you have a look at the results of the study that were published on the New England and presented at the last EAC, you see that the primary outcome at the patient level, so a patient composite outcome of death, myocardial infarction, stroke, and ischemia-driven revascularization was significantly reduced by physiology-guided revascularization, with the number needed to treat of 19 to reduce the occurrence of one primary outcome. This is the main publication of the study. Today, Andrea presented in the first late-breaking session the study, the sub-study on QFR assessment in the study. So this basically is one of many probably publication afterwards. If we move to the case, so a typical FIRE trial case, a woman, 80-year-old, hypertensive, dyslipidemic, with chronic kidney disease, so moderate reduction in the glomerular filtration rate, and anemia. She called the emergency number, that is 118 in Italy, for ST segment elevation MI, and so she came to our attention in the cath lab. So this is the angio on the right coronary artery. You see here there is a, I would say, critical or nearly critical lesion in the proximal RCA, another lesion in the in the mid to distal portion of the RCA, but it was not the reason why the lady was coming to our attention, because she had an occluded circumflex artery, and obviously there was also some kind of intermediate disease in the LAD. So typical FIRE trial case, one culprit lesion circumflex, at least two non-culprit lesion, one on the RCA and one on the LAD. This was the treatment of the culprit lesion, so wiring, predilation with a small balloon, 2.0, then Supraflex Cruz stent 3.5/28 was implanted with the post-dilation 4.0. The vessel was huge, not just pain, complete ST segment resolution. So after the treatment of the culprit lesion, the patient was randomized to physiology-guided PCI. Then what did we do? We performed QFR, so an angiographic-derived fractional flow reserve estimation based on the projection that we acquired during the culprit, after the treatment of the culprit lesion. And then here you can see the results on the LAD. So what does the QFR tell you? It tells you that the vessel has not to be treated because the value is 0.84, so it's more than 0.80. That is the threshold that's similar to FFR. And what does it tell you about the RCA? On the contrary, for the RCA, you have to treat the patient and the vessel because the value is below, as you can see here, the threshold of 0.8 is 0.78. And what can you do? What you can do also with the QFR assessment is trying to understand which lesion needs to be treated and if you have to treat both lesions in order to achieve a good final functional result. And basically, in this case, what was done based on the QFR pullback was to treat only the proximal lesion. That was the most relevant one at the pullback because the residual QFR was around 0.90, that it's near to the threshold for a good post-PCI result. So what we did was to follow the plan. We pre-dilate the lesion, implanting one single Supraflex, post-dilated with non-compliant balloon 3.5, and you can see that the post-PCI QFR was actually very similar to the one that was predicted with a value of 0.93. You obviously add some kind of disease in the lesion you left behind, but it was not much, and we were happy about the result we got. So moving from the procedural management to the clinical one. What to do with this patient in terms of the APT? Because this patient is for sure a patient at high risk of ischemic events. Remember, older patient, MI, multivessel disease, multivessel intervention, but at the same time she is a high bleeding risk patient because she has the major criteria for bleeding and at least two minor criteria, for ARC-HBR criteria that are age and renal function reduction. So what we did within the FIRE trial was to try to understand first whether the management of those patients in terms of complete revascularization was equally effective in patients at high bleeding risk, and the answer is yes, it's equally effective because we saw that in high bleeding risk patient, that is 71% of our patient population, the complete revascularization strategy was superior to the culprit only one. And the second point I would like to make is that as per protocol, we suggested to treat those patients at high bleeding risk and high ischemic risk with short DAPT. So at most 1 month of DAPT, even if they were MI patients. The investigators somehow followed us in 60% of the cases. So 60% of HBR patients received 1 month DAPT. In 40% of the cases, they were not so sure to follow our suggestions, so they decided to go with a longer DAPT regimen. So we were able actually to compare those two DAPT regimen, and you can see that there was no difference in terms of ischemic events in between HBR patients treated with short or longer DAPT. But if you look at the occurrence of major bleeding as BARC 325, you can see that shorter DAPT was superior to longer DAPT. So actually this is very reassuring in the treatment of those patients with short DAPT, and probably this is also thanks to the platform we used in the study that was Supraflex Cruz in most of the patients enrolled in the FIRE trial. So in conclusion, we can say that the FIRE trial for sure supported physiology-guided PCI over culprit-only strategy in older MI patients, that HBR patients have the same benefits related to complete revascularization as compared to non-HBR patients, and that short DAPT behaved well also in the FIRE trial population. Thank you very much for your attention.
So I think a wonderful presentation, a topic which has been recognized by the editorial board of the New England. That's a sign of quality. Answering an important question in a population which is frequently underrepresented, the elderly. Okay, so that's very good. And then I think that you answer partially the question, and I would like to ask your partner in crime, because these two guys are working together all the time. So, Gianluca, you have a question for your partner. I hope you didn't give the answer in advance.
No, Simone. I believe we are stressing the importance of the safety of the device. So if you can give some insight regarding stent thrombosis in the FIRE trial, in particular putting in the context after the recent publication of the FURREVAST trial, where the results are totally different.
Yes, because that's actually a very good point. In the FIRE trial, we saw that the definite stent thrombosis was less than 1%, and it was completely similar among the two arms. So there was no increase of stent thrombosis by treating more lesion, more complex lesion, more non-culprit vessels, calcific lesion, and so on. On the contrary, in the FURREVAST trial, what we saw is that if you have a look at the comparison between the two arms, so the complete versus the culprit only, you saw actually an increase in stent thrombosis rate in the complete arm, meaning that if you treat more patients with the stent platforms that were used in the FURREVAST trial, you may have some additional risk for the patient. That was not what we saw in the FIRE trial.
Very good. I'm sure that Joanna has a question for you, because
you know, I always love to work on prediction models, and are there any predictors who actually benefits the most from complete revascularization? Have you identified any groups that maybe you should avoid?
Yes, another very well taken point. Yeah, we performed a subgroup analysis for the main paper, and the groups that we analyzed were not different in terms of response to the treatment. So the short answer is no. What we started to see, and we're focusing on it, is that the most complex was the patient, the greatest was the benefit related to the treatment. So for example, chronic kidney disease, in patients with chronic kidney disease, we saw that, but obviously it's my sensation, it's not something that I can tell you with p-values, but that the benefit tended to be higher.
I think you sort of answered my question with your case, because you used QFR. You used it only in 20% of the cases, but I think probably that patient with CKD, if you've treated all the lesions, LAD and the distal right, might not do as well as just treating the proximal right and being selective based on QFR. So maybe the benefit would have been better if 100% was done with QFR.
It's
Thanks.
more common than a question. Yeah?
Yeah.
Okay, thank you very much, Simone. So it's a pleasure to introduce Pieter Smith for the Compare 6080.
Thank you, Patrick. It's also a pleasure to be here and to present to you the Supraflex Cruz use in patients with high bleeding risk, the results from the Compare 6080 HBR trial. This is my conflict of interest slide. And let me start with a case, a typical case from the Compare 6080 HBR study. It's a male patient, 76-year-old, known with proximal atrial fibrillation and also known with the cabbage, and also known with chronic lymphatic leukemia and aortic stenosis with hydronephrosis and renal dysfunction. Also known with stable angina for a long time, and a positive exercise test that gradually progressed. And he had underwent coronary angiography, in which the lima was not placed on the LAD, but it was placed on the intermediate branch. And there was a FREMA graft, Y graft, to the anterolateral and amargobtusal branch. It was dysfunctional, and he was already known with the severe left main stenosis. Based on his comorbidities, the heart team decided to go for PCI of the left main. So this patient had, according to the ARCH ABI criteria, two major criteria. You can see he was on OAC and he had an active cancer. And he had also two minor criteria. His age was 76 and he had a GFR of 45, so moderate kidney disease. So according to the HBR criteria of ARC, you have to have at least one major or two minor. And in this case, we had two major and two minor. So this was truly a severe high bleeding risk patient. And if you also look at the precise depth score, it was 28, it's above 25. It's also indicating a high bleeding risk patient, though the high precise depth score was not developed for patients on OAC. So this is the diagnostic angios. Here you can see the lima on the intermediate branch, and you can also see the string sign of the Y graft, which is dysfunctional. This is the distal left main stenosis. Difficult to see if the stenosis progresses into the left in the LAD of the circumflex. In the spider view, you can also not really good appreciate it. You can still see the intermediate branch where the lima is placed with the kickaboo sign, and only in the spider projection you can think that there can be some proximal circumflex disease. We did, of course, IFIS as a start to investigate the bifurcation, and you can see that when we draw back from the LAD into the left main, you have first the intermediate branch that's coming off, and then you have here the circumflex where you also have the stenosis. Here the ostium of the circumflex does not seem that bad. The proximal of the shaft of the left main is quite well, and you can see the dimension of the left main 3.7, 4, and 4.5, and on proximal LAD 3.2 and 4.1. We progress after pre-dilatation of the left main LAD, putting in the Supraflex 4.020, and then we did this control angio, and then you can see that there was still some plaque shift towards this ostium of the circumflex, and I decided to treat the circumflex at that moment as well. After pre-dilatation, we implanted a Supraflex 3.016, and it was a kind of a T stenting, and after kissing balloon and a pot of 4.5, 12 non-compliant balloon in the left main, we finished the case. And this is the end result of this bifurcation left main. And as you can already discuss, it was already presented that this proximal, that is 4.0 stent, Supraflex Cruz stent can be extended up to 4.5 millimeter, and that for bifurcations you have a largest cell area with the Supraflex stent, so that is really convenient to perform those bifurcation treatments. I forgot to mention that the patient was discharged with a lower dose dabigatran because he had renal dysfunction. We gave at that moment 1 month aspirin and 6 months clopidogrel. So let me continue with the results from the Compare 6080 HBR trial. It's a randomized controlled multi-center trial comparing the ultra-thin strut Supraflex stent with the thin strut Ultimaster stent in the high bleeding risk patients with abbreviated DPT. Our objectives was the following: to show non-inferiority between the ultra-thin strut Supraflex Cruz stent and the thin strut Ultimaster Tansai stent in the population at high risk of bleeding. And our hypothesis was that in the PCI population with short DPT, the benefits of using an ultra-thin strut DES might be enhanced compared to a thicker strut new generation DES. This was a multi-center randomized study performed in the Netherlands. 11 Dutch sites participated in this trial, and we enrolled in total 736 patients, 371 in the Supraflex and 370 in the Ultimaster arm. We did the intention to treat or the full analysis as a primary endpoint. We also did a per protocol analysis, where we excluded a few patients with some major protocol deviations. The baseline characteristics, you can see here, the average age is around 75 years old, 10 years older than the average PCI population, really reflecting a high bleeding risk patient population, diabetic, almost 30%. Truly a high bleeding risk. You can see HBR, ARC HBR criteria, more than one major, more than 70%, and more than two minor, more than 50%. The majority of the patients were treated for chronic coronary syndrome. This is the antiplatelet regimen in our trial. As you can see, that it was similar for both arms. Interesting to see is that at discharge already 1/3 of the 30% of the patients had only single antiplatelet therapy. That increased up to 1 month to more than 60%, and at 6 months a quarter of the patients had no antiplatelet therapy, and that increased up to 40% at 12 months follow-up. The median depth was 30 days, and it was similar for both arms. So this is the primary endpoint, NACE, the composite of cardiovascular death, MI, target fascial visualization, and stroke, and bleeding BARC 3 or 5. You can see for 17.1 for Ultimaster and 15.4% at 1 year for the Supraflex Cruz stent. And with this difference of 1.65, it does not cross the border of non-inferiority. So non-inferiority was significantly reached with a p-value of 0.02. We also did superiority testing. Unfortunately, the study was underpowered to show superiority. And we also did a per protocol analysis and also reaching significant benefit, non-inferiority with a p-value of 0.02. We also looked at, of course, the individual components of the composite endpoint: cardiovascular death, myocardial infarction, target vessel revascularization, and stroke. Cardiovascular death, no difference. On myocardial infarction, a numerically benefit of the Supraflex Cruz stent compared to the Ultimaster stent, as well for target vessel revascularization, a numerically benefit only, and indeed for stroke, we see a little bit on the opposite direction. So in conclusion, ladies and gentlemen, in this high bleeding with PCI population with short, median 30 days, depth treatment, the Supraflex Cruz stent was non-inferior compared to the Ultimaster Tansei stent, and outcomes on target lesion revascularization and myocardial infarction were numerically lower for Supraflex Cruz, however, not reaching statistical significance, including superior testing on NACE. Thank you for your attention.
Professor Smith, thank you for an excellent presentation. The results are very encouraging to use a short depth in thin struts, stents. Maybe I will just open the floor to panel for any question. Maybe you have a question here?
Sure. So in your own practice, clinically, do you ever reach for a thicker strutted stent for any particular lesion characteristics? Or do you say, well, we should all use only 60 micron stents?
Depends on what you define as a thicker strut, but let's say the 80 microns or more is a thicker strut stent. In my practice, I don't see any difference anymore between the thin strut and the ultra thin strut stents. And we also did this, but I did not show, but we also did a QCA core lab analysis of the first 200 patients, and the acute gain, if you look at the radial strengths, was absolutely similar between both stents.
Perfect, thanks.
So I think we have another question there from Valeria.
Yes. Pieter, during the conduction of the trial, the APT regimen was adjusted according to the evolving guidelines on the APT recommendations. Do you think that this adjustment affected the clinical outcomes? In which way? Can we assume can we speculate that probably a more consistent, shorter DAPT would have yielded even better outcomes of these results?
Yeah, that's a nice question and very intriguing as well. And I certainly believe that there could be a potential signal towards a better outcome with ultra-thin stents with an even shorter DAPT. Yeah, indeed, we had to change. We changed our DAPT recommendations during the trial based on the guidelines. Yeah, there's a potential benefit in shorter DAPT with ultra-thin stents.
Very good.
Thank you very much.
Yeah. So we continue, and it's a real pleasure to... You go first before Upendra?
Yeah.
Pruthvi? Okay, good. So go ahead. Yeah?
Good afternoon, everyone. I will be presenting a topic called Contemporary Best Practice with Supraflex Cruz in patients with 3-vessel coronary artery disease in the ongoing multi-vessel talent trial. I come from Corib Research Center for Advanced Imaging from Galway, and I work with Professor Serruys and Professor Numa. I don't have any conflicts of interest. So the multi-vessel talent study is a prospective, open-label, multi-center, randomized control trial comparing clinical outcomes between Supraflex Cruz and synergy drug-eluting stent. Patients with de novo 3-vessel disease without left main disease are treated according to the state-of-the-art PCI after selection based on syntax score 2 treatment and heart team discussion. Functional evaluation for stenotic lesion by quantitative flow ratio, intravascular ultrasound or OCT guided PCI to optimize PCI outcomes, and if there is any CTOs, contemporary CTO techniques will be employed, and optimal medical therapy, which involves 1 month of DAPT involving aspirin and prasugrel, followed by monotherapy with aspirin for 12 months. So the primary endpoint is non-inferiority for POCHE at 1 year, and powered secondary endpoint is superiority for POCHE at 2 years. So these are the baseline characteristics of the population. The mean age is around 68 years, mean LVF is 55%, prevalence of diabetes is 30%, and prevalence of ACS is 31%, and prevalence of dyslipidemia is 73%, and hypertension is around 75%. These are the lesion and procedural characteristics. The prevalence of CTO is 9%, bifurcation lesions is 18%, anatomical syntax score is 22, syntax score per lesion is 5.7, number of anatomical lesions per patient is 4, number of physiologically significant lesions per patient is 2.2, number of lesions treated per patient till now is 3, number of stents per lesion is 1.4, stent length per patient is 88, and number of stents per patient is 3.6. And MSA by IVUS, which was employed in 67%, was 6.2, and MSA by OCT is 6.1. So this is the anatomical syntax score of the population. 62% of the population have an anatomical syntax score less than 23. 28% have intermediate, that is between 23 and 33, and 10% have anatomical syntax score more than 33. I would like to show a case employing state-of-the-art PCI practice. So a 73-year-old male with dyslipidemia and hypertension and family history of CAD presented with class 3 stable angina. He was on antihypertensives and statin ezetimibe combination for lipid lowering. Cardiac troponin was not elevated. LVEF was 69%. So this patient had a tubular lesion in segment 1, moderately calcified lesion in segment 6 and 7, an intermediate lesion in segment 11. The diameter stenosis by QCA and L6 was 46%. QFR was positive for ischemia in RCA and LAD while negative in LCX, so decision was made to treat RCA and LAD. Syntax score 2 was calculated, which showed lower absolute mortality risk with PCI, so the heart team decided to treat the patient with PCI. So, considering the calcified lesion in segment 6 and 7, patient underwent rota ablation and IVL to modify plaque, followed by implantation of 2 overlapping drug-eluting stents in LAD. And segment 1 was pre-dilated with a semi-compliant balloon, followed by implantation of 2 overlapping drug-eluting stents with good angiographic result. Post-PCI QFR was more than 0.90 in both vessels. So intravascular imaging was done after the PCI, which showed a minimum stent area of 5.1 millimeter square in LAD and 8.2 millimeter square in RCA. So ultrasonic flow ratio post-PCI was more than 0.90 in both vessels. So we used a logistic regression model developed based on the results of Syntax 2 study, which employed similar design to multivessel talent to predict OCHE. The Syntax 2 also employed state-of-the-art PCI practice. Using the first half of the study population, that is first 775 patients in the trial, the predicted vessel-oriented composite endpoints is 6.1% at 2 years with a prediction interval of 4.8 to 7.4%. So far we have enrolled 90% of the patient population, and the trial will finish soon. This is one more case we did in EuroPCR 2024, which used state-of-the-art PCI practice guided by CCTA. The case was an 81-year-old male presenting with class 3 angina with no previous history. LVEF was 69%. So this is a CCTA which shows calcified nodules in the RCA with mild stenosis. The end of the left main stem was heavily calcified with involvement of the bifurcation with LAD and LCX. Circular calcium also involved the bifurcation of LAD with the diagonal. The anatomic syntax score was 24 point. The syntax score 2020, which predicts MACE at 5 years and all-cause mortality at 10 years after either PCI or CABG, showed that all-cause mortality at 10 years was similar between PCI and CABG, and 5-year MACE was similar between PCI and CABG. So the heart team decided the patient would be treated with PCI. So using CCTA, we did an analysis to guide PCI. So the ostium of the left main was large with a MLA of 16.9 millimeter squares and a diameter of 4.3 mm. The distal part of the left main had a MLA of 3.24 and MLD of 1.2 with a 70% diameter stenosis and was heavily calcified in a concentric fashion. The origin of LAD had a respectable MLA of 6.7 but was calcified in 2 quadrants. The ostium of circumflex had an eccentric calcium. The distal LCX had a diameter of 2.7 while the reference diameter for LAD was 2.98 mm, which gives some information about what kind of stent could be used. The length of lesion was 25 mm. Obviously the FFRCT in the LCX and LAD were very low. So using CCTA, the strategy of left main PCI could be predetermined. Since the sinus of Valsalva had a diameter of 2.8 centimeter, 7 French EBU 3 guide catheter was selected. Considering the heavily calcified circular plaque in the main stem, upfront lithotripsy device was selected. The working angle to guide and cannulate the left main ostium with the guiding catheter would be LAO 20 degrees and cranial 30 degrees, while the largest bifurcation angle would be seen in LAO 50 and 35 degrees. The planner software is used to predict the result of virtual treatment. So if we implant a stent of 25 mm with a proximal diameter of 4.3 and a distal of 3 mm, the FFRCT post-PCA would be 0.94, and we can see that the FFRCT in the diagonal after PCI was less than 0.80, so we can avoid the bifurcation lesion of LAD diagonal. So this OCT analysis was performed by Professor Yoshi, who is doing a case in Massey now. So patient underwent PCI from left main to LAD, and post-PCI OCT pullback showed a good result with good MSA and no edge dissection or under expansion or malopposition. LCX ostium was patent. So what next? So the Syntax 4 trial will be randomizing 2,500 patients with 3-vessel disease or left main disease to conventional angiography guidance or CCTA guidance for PCI or CABG. The trial will test non-inferiority for POCH at 1 year. The PCI arm will be using Supraflex Cruz in patients with 3-vessel disease and left main disease. So far, 300 sites have been approached in European Union. Thank you.
A nice presentation, Pruthvi. Of course, that trial is currently will be submitted to the European Union, so we don't have the guarantee that we will conduct it, but at least we will try very hard. I think that Helge has been very much involved. He's one of the PI of the multi-talent. And any question after this presentation, Helge?
Yes, actually, we are talking about multi-vessel disease, and a very strong part of this trial was the intracoronary imaging. Do you still think that this is of great importance? So we have Illumin 4 presented a couple of months ago, which was not so successful. It was actually a negative trial. Nonetheless, do you still think that the decision to use imaging was the right decision?
Thanks for a very important question. I think if we keep Illumin 4 apart, we have evidence from network meta-analysis involving 32 randomized controlled trials which compared PCI guided by angiography versus imaging versus physiology, and intravascular imaging guided PCI ranked the best for reducing MACE at 2 years. Also, there is a trial called Renovate Complex PCI, which was a trial in complex CAD patients, which showed that intravascular imaging guided by OCT or IVUS reduced outcomes. One more trial is complex CAD with bifurcation is October, where OCT guided PCI showed reduced outcomes. So I think intravascular imaging will soon make the guidelines.
Okay, let me booby-trap you, yeah? Okay. I saw a juicy circumflex, a big one, with a 46% diameter stenosis, and the physiology tell you don't touch that. Make me nervous. Make me nervous. So you have the IVUS on the table, because you have look after. Why not to look at these 46%? Imagine that you find vulnerable plaque of whatever.
Yeah, that's
what would you do?
It's a very important question because most of the cardiac deaths, like sudden cardiac death, is because of vulnerable plaque. So I would put a catheter in LCX and see the features for vulnerable plaque. Like there was a trial published in Lancet recently called Prevent, where they defined vulnerable plaque based on like MLA less than 4, plaque burden more than 70, and features of TCFR necrotic core. And they found that if FFR is more than 0.80, but they met the criteria of MLA less than 4 and plaque burden more than 70, at 2 years follow-up there was reduction in clinical events. So certainly I would stent if there is a like MLA less than 4 and plaque burden more than 70 with a TCFA or a necrotic core.
Okay, so it goes in the direction we should touch the vulnerable plaque. I made a comment for the Lancet. I will see what they respond, yeah? What will be their response. That was very good. Thank you very much, Pruthvi.
Thank you very much.
Now it's a real pleasure to introduce Professor Upendra Kaul. You will remember that a few years ago he published in the New England Tuxedo 1, okay? And he's a recidivist, so he has now a Tuxedo 2, and it's an old friend, and it's a pleasure to have somebody from India exposing the technology of the country.
Thank you, Patrick and friends. Well, this trial was conceived of by me and one of my friends in New York, because we thought India is the capital of diabetes and we are going on this tuxedo platform. So we thought, how about comparing the ultra-thin strut Supraflex Cruz with Xience? In multi-vessel disease, 100% patients with diabetes, 85% patients with triple vessel disease, and 15% patients with double vessel disease, as was happened in Freedom study. We have received academic grant from SMT for this. Basically, it's a prospective, open-label, multicentric 2x2 factorial design randomized study comparing these two stents in a complex patient population with established diabetes, and also comparing two antiplatelet regimes, prasugrel and ticagrelor, for composite of ischemic and bleeding events. And then finally, to pull up the data of the two stents and follow up these patients for 5 years and compare with the results of the CABG arm of the Freedom study based upon their performance goal analysis, not a 1:1 randomized study with surgery, but we get some kind of a answer from that. So basically, the hypothesis being whether the ultra-thin drug-eluting stent could provide a new choice for diabetics with complex multi-vessel disease, combined with contemporary medical treatment, high-dose statins and SGLT2 inhibitors and all the good things for managing diabetes. Well, they're randomized. Half of them go to Supraflex Cruz and half of them go to Xience, and then they're also at the same time randomized between these two antiplatelet agents. So let me, the study is still ongoing, so let me share you two cases. One is a 67-year-old male, class 3 angina, dyslipidemia, ejection fraction 50%. He has angiographic evidence revealing triple vessel disease, left dominant, RCA is small, highly calcified LAD, up to 90%, and long lesion in obtuse marginal 1 and obtuse marginal 2 is also significant disease. Distal circumflex and left PDA has 60 to 70% plaque. You can see the images. So first lesion to be dealt with was this large circumflex obtuse marginal, which was crossed, dilated, and a stent was put in. And as you can see, is post-dilated, and the result is good. Now we go to the OM1 using a plain balloon followed by a drug-eluting balloon at 14 atmospheres. We thought the vessel is too small and close to the ostium, so did not go with a stent in this. Then coming to the calcified LAD lesion, and there was this dog boning effect of the balloon because the calcification is severe, both in the proximal and mid-LAD. So finally, we give IVL pulses given to LAD using 3.5 into 12 millimeter balloon, IVL balloon, and then also about 10 pulses each to each side 3 to 4 times. You can see the sync vision of Phillips showing the waste not disappearing before the IVL therapy, and finally, after the IVL therapy, you can see the expanded balloon. The stent, using the randomized stent as per the protocol, we put in a long 38 millimeter stent in the LAD, and the result was good. Coming to the circumflex, distal circumflex lesion, what was done was a QFR, and it showed that the QFR was 0.90, so this was left. Otherwise, this would also have been handled. So this is the final result. Case number 2 is an 80-year-old gentleman who had a history of acute kidney injury, ejection fraction 35%. And these are the lesions: triple vessel disease, a long segment region of LAD, circumflex obtuse marginal, almost totally occluded obtuse marginal, and the right showing a long diffuse disease. So the LAD lesion being handled, pre-dilatation, putting in a long stent and getting a good result, followed by the OM1, getting a good result, putting in a long stent there, and then post-dilatation, finally coming to the distal circumflex lesion, dilating it, and then you can see the stent being deployed in the distal circumflex OM2 lesion and getting a good result. And this is the final result. You can see LAD, obtuse marginal, and the distal circumflex all being revascularized. Coming to the right lesion, it is again a long lesion, as you could see, dilated and putting in a long stent, post-dilated, and finally you can see the right coronary artery also gets very nicely revascularized. So triple vessel complex disease showing that complete revascularization of all the vessels. So the status of the study as of this morning has been 1644. After this slide was made, 2 more patients have been put in, so it is now 1646. The baseline data, the age is almost the same, around 60 years in both the groups. The left ventricular ejection fraction is close to 50, and most of them, predominant them, are type 2 diabetes mellitus. And as you can see, a large number of them have acute coronary syndrome, ST elevation MI, non-ST elevation MI, unstable angina. Stable angina only in 12% of patients, and asymptomatic hardly, just 2 patients in each series. The number of stents implanted per patient so far is 2.68 plus minus 1.04. The stent length has been 30 millimeters in stent group A and 24 millimeters in group B. The current status of the study is that we have recruited about more than 90% of the patients, and we are serially following them up to 12 months, 24 months, because the study started in late 2020. We also have follow-up of 200 patients with 36 months. So hopefully this study should finish by the recruitment should finish within 2 months, and hopefully 1-year result should be available by next year, July, and maybe we go to TCT with a late-breaking trial. Thank you very much.
Thank you, Professor Kaul. Excellent presentation. I think this is a very interesting trial to wait for, because I suppose this is the first time an ultra-thin strut has been used in diabetic population with multivessel disease. So really we're looking forward to the results next year. So I will open the floor to the panel if there's any questions. Valeria, maybe you have a question? Or Professor?
Oh, yeah. I did have a question, and again it relates to diabetics, because Professor Zaman in his registry demonstrated that diabetics were perhaps the biggest group who had the most complications, be it target vessel failure, target lesion revascularization, MI stent thrombosis. Which brings me to the 2 randomized trials, especially Simone, yourself, and Pieter, yourself, at 60-80. Did you notice any difference in diabetics versus non-diabetics with a thin strut device as a precursor to, just a hypothesis around the trial Dr. Kaul has embarked on?
If I may start, yeah, we did a subgroup analysis, of course, in our study, but we did the results were very consistent. So no differences between diabetics and non-diabetics. But the subgroups were small. We only had 730 patients in our trial.
Right.
Yeah, the same for the FI trial. We had 32% of patients who were diabetics.
Yeah.
So if you compare diabetics patient with non-diabetic patient, they had the same benefit of physiology-guided complete vascularization, but with a higher mean number of events compared to the non-diabetic patients.
And the male to female, because, you know, again, this was a 30% female population,
36.
or 35%.
Yes.
Are the females the same as males? It's an area of huge interest.
Exactly. They had the same benefit of male patients.
Yeah, the means in this group of patient population is definitely high, much higher than, you know, you get in non-diabetics because of the complexity of the lesions in triple vessel disease. There are, you know, CTOs and bifurcations and left mains.
Can I ask you, are you using imaging for this trial as compulsory, or is it just
imaging is desirable, but that's what we have 70 centers doing the study, and not all have facilities for imaging. About 25% of patients are having FFR and about 10 to 15% imaging.
I saw you also using QFR pre-procedure.
Yes.
Do you also check post, and then do you make a decision, for instance, if to use IVUS after, depending on what your post-PCI QFR shows?
Yeah, it all is depending upon center to center, because this has not been mandated. 1,800 patients, if you look for in our country and get them going with all IVUSs, I don't think it's possible. So I thought, you know, whatever we are doing on ground in India, we should present. And, you know, it's a big population, capital of diabetes.
I think 2 years ago we published in the European Heart Journal the 10 years follow-up of the syntax study. And what was amazing is that the diabetic, for instance, in all-cause mortality, no adjudication, the ultimate judge, there was no difference between the diabetic and the non-diabetic. But the insulino-dependent, that's where there is the problem. Yeah, that's really where there is the problem. But not in the common diabetic on diet of with oral hypoglycemia. So that works quite well in the long term,
20% of the patients in this study are requiring insulin. You know, they not many have to be dependent, but requiring insulin,
90%.
Any more questions from the panel?
Yeah, I think we were sort of curious, how do you convince the surgeon to let you do the case in a diabetic patient with three-vessel disease?
That's
What's
a
your strategy?
great challenge, because the biggest challenge is freedom study, because everybody knows about the freedom study. It had come in newspapers also that time. But the other challenges are that having stock of Zions as well as Supraflex Cruz of all the sizes in 70 centers is not easy. Number two, there are regulations by many, you know, funders that if you need more than 3 stents, patient should go for surgery. So these are some of the common challenges which we face, but you know, we tell the person, heart team decision is there that we can do equivalent revascularization, and surgeons so far have been quite, you know, generous in allowing us to do it.
You're lucky.
So let's see, we are coming to an end. I think that the audience must have the chance to ask a question. They can be shy, they can be prudent, but if there is a brave in the audience, go to the microphone and ask the question. We'll give you some times, and then we still have a few minutes to discuss. I would like to make 2 or 3 comments. The first one, like Faisal has said, what is very important with this technology, more important than I believed initially, is this long connector in zigzag, because it goes from valley to valley. Nobody has done that. You know, all did some S connector, sometime on the side, but not from valley to valley. And as you said, very good, there's a duality there. You have on one hand the flexibility, and on the other hand the pushability. And I think it's important to say. The second point is that when the people think about the thin struts, I know I've heard that, they are somewhat nervous about main stem. I can tell you there have been plenty of main stem treated with this case. And I think the case of Pruthvi is a good illustration to a full ring of calcium Of course, you did 10 sessions of lithotripsy for 10 seconds, but then the stent went through and deployed completely. The third thing, which is very interesting, is that in February, there was a publication in the American Journal of Cardiology. And that publication was done by the investigator of the ORCIRO of Biotronic. And they did a beautiful network meta-analysis, very professional. The result is interesting. When you compare 10 stents used in Europe, the number one for TLR and TV failure is the Supraflex Cruz, together with the mice stent. Two studies published in the New England. The mice stent, unfortunately, was never commercialized. Then you get the science, then you get the synergy, and then you get the ORCIRO. So we should really not be afraid to use that technology, because even by investigate of the ORCIRO, they came to the conclusion that that was the best. And the statistic in that paper is quite remarkable. You should read that paper. So I'm very pleased to work with that technology. We would not be there with the best in Europe to work on that if we were not convinced that it's a good technology. Now, in the meantime, you have formulate your question. No? Who wants to do that? Who is brave? A lady, because with the equity today, everybody. Otherwise, we will give Valeria another question, another chance to ask a question.
Yeah, we were talking about this technology, and unlike other thin stent struts, the DES, for this DES, we have that the strut thickness is really low across all the stent platform. So I would like to ask the panel, particularly I want to ask Simone, because in your FIRE trial, you enrolled all acute coronary syndrome patient, 35% ST elevation. You show a nice case of a woman with a medium big caliber of a circumflex with a high thrombus burden. So any concern about the metal to artery ratio?
Yes, that's a very good point. So we actually had a look into it, because in the FIRE trial, randomization was after the treatment of the culprit lesion. So in some cases, few cases, the operator and the investigator put another stent platform just for the culprit lesion and Supraflex Cruz in non-culprit lesion. So we had many cases with the culprit lesion treated with Supraflex Cruz, the vast majority, but we have some few cases with the culprit lesion treated with another stent platform. And we did not see any difference among the two groups. So obviously it's not randomized, it's still, to give you some insight into the trial, but we did not see any increase in periprocedural complication, nor reflow whatsoever.
Okay, is there more question in the panel? A second lady for a question, no? And then Ashok, yeah?
Yeah, I do. And of course, we've had a great session, and we've really, reflected on you got a lot of data around the benefits of this stent strut device. Now, obviously, the question comes, there are a lot of experienced operators around here. So are there any lesions, any vessels, any group where you think that this stent perhaps is not your stent of choice?
Well, I think it's about preparing. I think now with the current technologies and the imaging that is available, I think with the new OCTs, Ultron, high definition IVUS, if you could do that, and even a lot of trend is now towards CT-guided PCI. So if you have all that imaging information, I think you prepare well, you will fail less. But if you don't prepare it, then of course you're going to have those problems where stents are going to give up at some stage.
I think that Simone and other people, and I'm convinced that when you have diffuse coronary disease, when the PPG I index is going down all the way, and you don't know basically where you put your stent because there is not a sharp decrease in the QFR, then we are basically in trouble. And it's still unclear if the DCB could make an intermediate step to recuperate this diffuse disease create some remodeling, because it is create remodeling. The DCB paclitaxel clearly achieve 50–60% of remodeling, and then eventually, if it's not good enough in terms of QFR, improve by a stent. That's the question. It's clear that in another session we are going to present in the conclusion what is the future of drug-eluting stent and DCB. It's very difficult to get an answer to that. We have consulted people from the university, we have consulted the industry. It's a big challenge to see at what stage the DCB will really be there for maybe 40%, 50%. And it's clear that the interventional cardiology is going to what, I don't like the word hybrid therapy, because the hybrid always die. They don't get reproduced. But I like the blended, you know, a blended whiskey or a blended wine. That's the best one. And I think that you see now more and more stent, DCB, cutting balloon, sculpting balloon, lithotripsy, and so we have a wonderful, wonderful arsenal of armamentarium of device. But we should not forget the pharma, because the pharma is there, very, very powerful. You know, all these expensive silencing microRNA, which eliminate your PCSK9, your LPA, and so it will come. And we don't want to see the interventional cardiology be bypassed by a second, a third courage of ischemia, of orbita, or whatever you imagine. So we have really to take care of the secondary prevention of our patient to avoid that phenomenon. That's a little bit my message for today. Still, no question from the auditorium. Anybody in the panel who want to make an important statement? Joanna, back.
Well, let me just finish by saying that indeed an excellent stent platform. So last question to Pieter. With this stent and with TICA monotherapy, will we have to calculate HBR score for the patients, or can we just give everybody the SMT stent and ticagrelor monotherapy from almost day one?
Yeah, let's do that.
Glimpse to the future then.
Okay, I think we are going to stop this meeting. There is classically for PCR the message, if you could push the button, maybe there is a slide there, not very original, but we have to follow the advice of the PCR, which are very important. They try to be very educational, and that's a great benefit of this meeting versus other meeting in interventional cardiology. So, is that fair enough that Supraflex Cruz shows very low event rates in ongoing registry reflecting real-world clinical practice? You have seen the difference between the 2-point-something% and the 5-point-something%. Supraflex Cruz is safe and efficacious in high-risk patients encompassing elderly and high bleeding risk, and that's very, very important. Safety first. And then I think that from the ongoing multi-vessel talent trial and the Tuxedo 2 trial, employing the best PCI practice will provide some evidence and prove the efficacy of using ultra-thin strut Supraflex Cruz in patients with diabetes and complex CAD. We are in a difficult world, but I think that's a very good instrument. I'm not afraid to that. I have no conflict of interest, but when I see these networks, meta-analysis made by somebody else telling us that we have selected the good stent, that's important. And then we will try to do this very ambitious trial. As you know, we have published 2 months ago or 1 month ago in the European Heart Journal the fact that we go to bypass surgery without cine angiography. Now, if the surgeon can do that with very good feasibility, 99%, and great success, we interventional cardiologists, we should use more multi-slide CT scan to know that you are going to find a subtotal a main stem full of calcium. It's really a big advantage. So this Syntax 4 trial, if we succeed to convince the European Union that we have a good application, will be important, because I really believe that the conventional cine angiography will progressively leave the scene. I don't know if you are familiar with the photo counting multi-slide CT scan, which is unbelievable. I mean, it's a resolution of 100 micron. It's 2 times better than the cine angiography. So I think it's going to happen. How many years it will take, I don't know, but the process is getting very, very quickly. I heard that Siemens, for instance, has stopped the production of the conventional multi-slide CT scan and do only the photo counting. And I recommend you to look at these images. They are phenomenal. If the surgeon over the last 2-3 years were able to operate the patient without cine angiography, that's a message. That's a message that, that we should amplify. Why? Because if you eliminate this 35–40% coronary angiography who doesn't produce anything, I mean, the patient leaves the cath lab without any recommendation, even without improvement of the secondary prevention or primary prevention. We have to change that. We have to create space and time in the cath lab for many other things. You know, the valve, the left appendage occlusion, a complex CTO, etc. That's, I think, a little bit the message for your community. And I'm very pleased to see that SMT has decided to be the industrial partner in this application of the European Union. Half the industry, half the European Union. So we hope to be successful. If we are not, we will continue in that direction until we do the trial. Okay? Thank you very much.